Hey everybody, this is Joey Newbegin. This is a short intro to nerve blocks for our nerve block bootcamp session this summer. So why do we do nerve blocks? The one main reason is it hurts less, specifically for areas like the palm of the hand or the sole of the foot, where direct infiltration is going to be very painful. A nerve block may allow a smaller volume of local anesthetic to anesthetize the area, and it will also stop you from having any tissue distortion. So if you're sewing along the vermilion border or the brow, you don't want that freezing to puff up the tissues, and a nerve block can really make it a lot easier to see your landmarks. Lastly, they're a form of treatment for people with hip fractures or rib fractures to help them get more comfortable as opposed to just loading them with a bunch of analgesics and narcotics. Now, one of the important things you need to know is your toxic doses if you're using nerve blocks, because sometimes we use plain blocks and use quite large volumes. And if you're not paying attention, it's easy to exceed the toxic dose. Hopefully you'll remember that the toxic dose of lidocaine with epinephrine is 7 milligrams per kilogram, and without epinephrine is 4 milligrams per kilogram. So in a 70 kilo person, that's about 49 cc's of 1% with epi or 28 cc's of 1% without epi. One of the hard things is we keep telling you that it's milligrams per kilogram is the toxic dose, and yet on the bottle it's labeled as a percentage. Currently I see residents running into trouble figuring out how many milligrams is this percentage. So a 1% solution means that there's a gram of the drug in 100 cc's, which is essentially 1,000 milligrams in 100 cc's. So if you do the math, every milliliter or every cc has 10 milligrams of the drug. A 70 kilo guy for 1% with epi would be 7 milligrams per kilogram times 70 kilos, which is 490 milligrams would be the toxic dose. At 10 milligrams per mil, that would be a total of 49 cc's. Similarly, a 2% solution would be 2 grams per 100 cc's, so that would be 20 milligrams per mil, so then the toxic dose is only 24.5 mils. And a 0.5% solution would be 5 milligrams per mil. For bupivacaine or Marcaine, the toxic dose is 3 milligrams per kilogram with epi and 2 milligrams per kilogram without epi. If you do the math, that would turn out to be, in about a 70 kilo guy, 42 cc's max with epi or 28 cc's max without epi. Usually in a local infiltration form, we think of lidocaine as lasting about an hour and bupivacaine maybe 4 hours, but in a block form, where you're getting the nerve higher up, the onset is a little slower. Lidocaine takes about 10 to 20 minutes to kick in, but the block's going to last 2 to 5 hours, longer if you use epinephrine. Similarly, bupivacaine takes quite a bit longer to kick in, about 50 to 30 minutes, but that block can last 5 to 15 hours, and even longer in a proximal nerve with epinephrine. It's important to remember that if you're using epinephrine, that in large volumes, it accumulates to quite a high epi dose. So in a 30 mil block, with a 1 in 100,000 mix of epinephrine, that's actually giving the patient 0.3 milligrams of epi, so it's like giving them an EpiPen. So you just have to be aware of that if you're giving a block to somebody with some fragile cardiovascular status. There are generally 2 types of local anesthetics. There's the amides and the esters. And to keep this straight, if you think of the generic name, if there's an I before the caine, then it's an amide. So typically we use amides in the emergency department. Lidocaine and bupivacaine are amides. And if people have liver disease or have some bad CHF, you just want to lower your potential toxic dose because they can't metabolize it as fast. The esters we use less frequently in an intravenous form, but that would be tetracaine or cocaine. And you got to watch these in people that have pseudocholinesterase deficiency because the drug is going to last a lot longer. Complications of nerve blocks and local anesthetics. One of the most concerning being CNS last or local anesthetic systemic toxicity, which can be as minor as just a bit of a metallic taste in the mouth or some tinnitus, but can be more severe with agitation, seizure, coma, and respiratory depression. Patients can also get cardiovascular last, characterized by bradycardia, ventricular arrhythmias, and hypotension. It is very unlikely for you to see CNS or cardiovascular last if you are under the toxic doses and you are sure you're not injecting into a vessel. People can be allergic to local anesthetics. Typically it's a class effect, either the esters or the amides, and actually most commonly they're allergic to the preservative that's in the local anesthetic. If you ever need preservative-free lidocaine, you can always go to your crash cart because our cardiac lidocaine is pure 2% lidocaine, which can be diluted 50-50 with some saline to get a 1% solution. If patients have a true allergy to pure local anesthetics, you could use a 1% Benadryl solution. So just take 1 cc of your 50 milligram per mil IM or IV dose of diphenhydramine and dilute it in 4 cc's of saline, and that'll give you a 1% solution. This is for local infiltration only and shouldn't be used for nerve blocks, but it'll give you 25 to 30 minutes of some pretty good local anesthesia if you had to repair a wound. You just have to watch for the typical anticholinergic syndrome and sedation if you use too high a dose. Other complications are an epinephrine reaction if you get into a vessel or use too high a dose, methemoglobinemia. Neuronal ischemia or injury is pretty rare in the emergency department setting, where we're doing single shot blocks as opposed to placing nerve catheters. And if you move your needle around too much, you can get a vascular injury or get into a vessel. And if you don't do it cleanly, you can get an infection. And always there's the risk when people are getting poked that they have a vasovagal reaction. So you want to make sure they're always lying down or at least seated before you do any of these kind of blocks. So how do you avoid these complications? Well, first, as we've talked about, be conscious of your dose. Think about it before you inject anybody and calculate your max that you can deliver. Always use a clean, aseptic technique and avoid injecting into paresthesias. That could mean you're into the nerve. Inject slowly to allow the freezing to spread and not get into a nerve. And aspirate frequently to make sure you're not into a vessel, especially if you're doing blind blocks. There are some recommendations that if you're doing a big block in a proximal nerve, so more than 20 cc's in either like a femoral nerve or into the brachial plexus, that you have them monitored while you're giving that block. And repeat blocks, meaning kind of, oh, I put a block in, that one failed, I'm going to try again, are always risky because it's likely that you're going to exceed the toxic dose, or you may put a bit of extra pressure on that nerve with a high volume. Bupivacaine is much more risky from a cardiovascular perspective, so get comfortable using lidocaine first, and once you get really good at your nerve blocks, then start using bupivacaine. Only use epi if it's needed. So the reason to use epi is to make your block last longer, and it also gives you a little bit higher toxic dose. But if you don't need the volume and you don't need it to last long, don't use epi. It just increases the risk of neuronal ischemia. As mentioned, if you're using amides, be cautious if they have liver disease or CHF, and ideally, for blocks that you can, use ultrasound guidance because you know exactly where your needle tip is going to be. Watch your anesthesia spread, so you should see it kind of move around that nerve. If you're injecting and you're not seeing the freezing come out, you could be injecting into a vessel. Start with doing ultrasound guided wrist blocks. This is easy country where you're unlikely to run into any complications, and good practice for guiding your needle and injecting freezing into a fascial plane. Lastly, always document your block. Certainly put it in the chart, but also if it's a patient that's going to be admitted, at the insertion site of your block, write on the patient in Sharpie that you've done this block. That way, if an anesthesiologist comes along to do a block, they'll know that somebody already put one in. So last is the most dangerous complication that we could encounter, and the American Society of Regional Anesthesia does say that we should be using monitors and have IV access for any of the big proximal blocks that we do. You do want to be on the lookout for it though, so keep in tune with your patient. Ask them to tell you if they're getting any kind of tinnitus or weird metallic tastes or feeling palpitations. You want to know where your recess gear is, and essentially the approach is very similar to an ACLS approach to any kind of last reaction, with a few caveats. Those mainly being benzodiazepines for seizures as opposed to Dilantin or any kind of other anticonvulsant, and a reduced dose epinephrine. So they usually say about 1 mic per kilo. So usually instead of giving a milligram, you're usually giving 100 micrograms. And probably the most important thing to consider early on is giving lipid emulsion or intralipid. It's kept in the Pyxis in section A, and it's a dose of 1.5 cc's per kilo or a max of 100 cc's. In our nerve block box is a copy of the ASRA last toxicity protocol that goes over the dosing of lipid emulsion, the bolus followed by the infusion. Now, even though local anesthetics are used to prevent pain, the reality is they hurt when they go in. So what are some tips on how to ease the pain of injecting local anesthetics? The first is actually to buffer it with bicarb. And that means adding about 1 cc of sodium bicarbonate to every 10 cc's of lidocaine, or 1 cc of bicarb to 30 cc's of Marcaine. It's just the crash cart bicarb. I don't do this for everybody, but I certainly do it for all of my kids, and if you have a particularly squeamish patient, it's a kind thing to do. Use a small needle. Pricks hurt. Don't use anything bigger than a 25, and oftentimes use a 27 or a 30. Inject the freezing slowly. I see a lot of people just hammering the freezing in fast, I guess to try to shorten the duration of pain, but it hurts a lot less if you just slowly infiltrate that tissue. Warm your freezing to body temperature. So when I'm sewing up a kid, before I even set up my suture tray, I'll grab my freezing, I'll buffer it with bicarb, and then I'll put it in my breast pocket of my scrubs. Then I'll set up my tray and get the kid in position and things. So by the time I'm ready to go, the freezing is already body temperature and it hurts a lot less. Every time you puncture that epidermis, it hurts. So if you have to redirect your needle, don't quite completely exit the skin. Come very, very shallow, then redirect, and then advance again. So if you avoid that repuncture, it hurts less. Just before you inject, or even while you're doing the injection, it's good to flick or shake or even kind of pinch some skin nearby, and that'll flood the nerves that go to your brain as a bit of a gate theory and will block some of the pain. Similarly, flood their brain with other things, so talk to them, have them look at an iPhone, something that will distract them while they're getting the painful injection. We don't have that in the Emerge at KGH, but some centers have some cold spray, which is good to do on the skin just before you inject. And lastly, if you do have to use a bigger needle or do a deeper block, it's nice to do a little small superficial wheel of freezing at the injection site before you put the bigger needle in. For our ultrasound blocks, remember nerves look kind of like honeycomb. They've got that white epineurium membrane around the outside and some kind of echoleucent fascicles on the inside. And we're not actually aiming to inject the nerve, right? We're always looking to inject that little bit of fascia that's right beside the nerve. So floating that needle in there and then injecting freezing that's going to float all the way around the nerve. It's great if you can get 100% coverage of freezing all the way around that nerve. However, if you even get half of the nerve covered with freezing, the block is going to take a little longer to kick in, but it's still going to work. Remember, nerves have this property called anisotropy, which means if you're not perpendicular to the long axis of the nerve, the beam's going to bounce off and the nerve will be echolucent, and when you're perpendicular, it's going to be echogenic. So if you're having trouble finding the nerve, fan that probe at different angles, and usually that nerve will start to light up. For the majority of our blocks, we're going to be using an in-plane technique, meaning the beam of the probe, or the probe itself, is perpendicular to the long axis of the nerve, so the nerve just looks like a little circle. But the needle is coming parallel to the beam. So you'll see the whole shaft of that needle from the tip to the end coming in towards that nerve. Occasionally, where real estate is really tight, like around the ankle, doing a posterior tibial block, we'll do an out-of-plane technique. So this is where the needle is perpendicular to the beam, and so you'll only see the tip. This is quite a bit more difficult, but sometimes we're forced to do this because there's just not enough room to track the needle in long axis. This is an example of a beautiful block of a median nerve. So you can see the needle coming in plane, heading right towards the fascia beside that median nerve. And the operator's just slowly kind of injecting, opening up that fascial plane and starting to just little bits of freezing, dissecting that nerve away, repositioning the needle. And note, you can see the little bevel of the needle. They're keeping that in view the whole time and slowly advancing, putting more freezing, dissecting that nerve off until they've got 100% coverage around that nerve. That's going to be a great block that's going to kick in fast. That's what you want to shoot for. This is the type of gear you're going to need to do your nerve blocks. You need some kind of cleaning solution. You need some kind of a probe cover, either a Tegaderm or a sterile sheath. Sterile sheaths are probably better, but this is a pretty clean procedure. You need a needle for your freezing, and you either need, if it's a short block, just a 25 gauge 1.5 inch needle or a 3.5 inch spinal needle. The problem with those needles is that they're both sharp and shiny. The sharpness can be a problem because unless you're watching your needle really well, you can poke that needle into the nerve. And the shininess makes it a little bit harder to see because the beam bounces off in all different directions. However, sometimes that's the only needles you have. What is better, although more expensive, are these blunt echogenic needles. This brand is Pajunk, and these needles are great because there are little ridges all the way along the end that allow you to see your needle better when the ultrasound beam hits it. And also the tip is blunted, so when you go through the fascia, you can feel a little palpable click and have a much better sense of where your needle is. You can do a 1 or a 2-person technique. The 1-person technique, you're controlling the syringe and the needle, so you have to have the hand coordination to push while you're guiding the needle. The other option is connecting your needle to some connecting tubing and then to a syringe, and have an assistant inject the freezing on your signal. And your only job is just to guide the needle under ultrasound guidance. The last 2 things to emphasize are always make sure you have a good line of sight. You should be able to see your needle and your ultrasound machine without moving your head, just with moving your eyes. And remember, what's the enemy of ultrasound? Air. So when you're loading up your freezing, make sure you have no bubbles in your line, or as soon as you inject, you're going to block your whole image. It's all going to get scattered. And that's it. So we're looking forward to seeing you guys soon in our summer course, and we're going to work on some blind and a lot of ultrasound guided blocks. See you soon.